Hi, everyone. My name is Sravya Gundapaneni, and I am one of the biomedical research interns here at Berkeley Pharma Tech. I am a current third year medical student at Ross University School of Medicine, and I just started my clinical rotations. I'm not sure exactly what field of medicine I want to go into just yet, but I've been extremely interested in gastroenterology academically and clinically. That is why today's presentation will focus on the current treatment methods for upper gastrointestinal bleeding, as well as future management options. I chose this topic because upper GI bleeds require emergent care in a hospital setting. And any technology or innovation that can slow the bleeding or decrease the chance of a rebleed has the potential to save countless lives. My objective for this presentation is to provide clear and concise information to those who work in the healthcare field about current treatment options for an upper GI bleed, as well as new management options that are becoming more readily available. I want to focus on the advantages and disadvantages of each innovation and hopefully shed some light onto why further research on this topic is crucial. Now, what is upper gastrointestinal bleeding? It is bleeding that is proximal to the ligament of Treitz. The ligament of Treitz is also known as the suspensory ligament of the duodenum. The anatomical landmark helps surgeons denote the duodenojejunal junction and the point where the small intestine passes from the retroperitoneal duodenum to the intraperitoneal jejunum. As I mentioned previously, an upper GI bleed requires emergent care. According to a research article by a gastroenterologist at Emory University, there are more than 1 million hospitalizations each year for upper GI bleeding in the United States, with a mortality rate of 2 to 10%. That means that between 20,000 and 100,000 people are dying each year from upper GI bleeding just in the United States alone. It is also important to note that upper GI bleeding can be divided into two categories: variceal and non-variceal bleeding. The image to the right is a picture of a variceal bleed. Esophageal varices are enlarged veins that develop usually in the lower esophagus when blood flow to the liver is blocked. This causes blood to flow into smaller blood vessels that are not meant to carry large volumes of blood. Due to this, the vessels can rupture and cause life-threatening upper GI bleeding. In the image, the rupture is on the right side and the blood is spewing into the esophagus. Non-variceal bleeding can be caused by a multitude of things, which we will discuss on the next slide. There are many different causes of upper GI bleeding. This list is not exhaustive, but some examples include esophageal varices, like I already mentioned, chronic NSAID use, peptic ulcer disease, Mallory-Weiss tears, aortoenteric fistulas, and malignancies. Upper GI bleeding manifests a little bit differently than lower GI bleeding. Although hematochezia, which is bright red blood in the stool, can be seen in some cases of upper GI bleeding, it is mainly an indicator of a lower GI bleed. On the other hand, hematemesis and melena are common indicators of an upper GI bleed. Hematemesis is the vomiting of blood, and melena is the passage of black tarry stool. Several treatment options currently exist for an upper GI bleed. We will briefly discuss the options for a non-variceal and variceal bleed. A dilute epinephrine injection can be given at the site of bleeding to temporarily reduce blood flow and cause vasoconstriction of blood vessels. Thermal probes are devices that deliver heat to the bleeding site to induce thermocoagulation. Argon plasma coagulation is a non-contact thermal method that uses steam of ionized gas to conduct electricity for the coagulation of bleeding tissue. Hemostatic clips are used to grasp vessels or surrounding tissue. This is comparable to surgical ligation. Next, band ligation is a technique in which the doctor uses an endoscope to suction and pull the varices into a chamber at the end of the scope. The doctor will then wrap the varices with an elastic band to stop the bleeding. The band essentially strangles the veins so that they can't bleed anymore. And lastly, cyanoacrylate is a strong, fast-acting adhesive that can be injected at the site of esophageal varices for bleeding cessation. However, the injection can be difficult to perform in inexperienced hands and can cause complications such as systemic embolization and ulceration. Today, I'd like to talk about 4 newer management options for an upper GI bleed. Although some of these have been around for a while now, they are becoming increasingly popular for a multitude of reasons. The first is a Doppler endoscopic probe. This was first developed in 1982 and used for the treatment of ulcers, but researchers have recently regained their interest in this probe. The over-the-scope clip was first introduced in 2007 for gastrointestinal tissue approximation. It was then successfully used in 2009 for non-variceal upper GI bleeding. Next, we will talk about hemostatic powders. Interestingly enough, hemostatic powders were first used in the military to treat combat-related hemorrhages. However, in 2011, they were adapted to upper GI bleeding. And lastly, endoscopic ultrasound-guided treatment is commonly used for gastric fundal varices and was first reported in 2007. First, we have the Doppler endoscopic probe. This isn't a physical clip or powder that is placed at the site of bleeding. However, it is an aid to get immediate intraprocedural feedback by measuring arterial blood flow. This helps physicians estimate the risk of a rebleed. The Doppler endoscopic probe is passed through an endoscope and can measure blood flow under a mucosal surface. It is currently commonly used to measure blood flow in high-risk lesions, ulcers, and diverticular hemorrhage. Hemostasis is achieved by endoscopic therapies with successful ligation of an underlying artery. The disadvantage of this probe is that it requires specialized training, which is why it has a limited availability outside of major academic medical institutions. Many studies have proven that mechanical hemostatic methods are more effective than injections or thermal modalities. The over-the-scope clip is currently approved by the Food and Drug Administration as first-line treatment for bleeding ulcers, arteries less than 2 millimeters in diameter, colon diverticula, and polyps less than 1.5 centimeters in diameter. The over-the-scope clip system is a full-thickness suturing device designed for flexible endoscopes. It consists of an applicator cap with a mounted clip, a hand wheel, and a thread retriever. Through a simple mechanism, the clip is deployed to the target to achieve hemostasis and close any perforations. The advantage of this clip are that it has significantly higher tensile force than the regular hemostatic clip and can treat larger mucosal surfaces. On the other hand, the clip is difficult to close hard, chronic, and severely fibrotic lesions and is time-consuming, especially in emergent situations. The physician must be extremely careful when using the clip because stenosis of the GI tract can occur if placed inappropriately. This image is from a journal article by Dr. Yang, a gastroenterology fellow at the University of California, San Diego. It shows the over-the-scope clip being used for a large visible vessel. The image is of a 51-year-old man with a Roux-en-Y hepaticojejunostomy with loop gastrojejunostomy due to complications of a prior cholecystectomy who developed hematemesis and hemorrhagic shock. An upper endoscopy revealed large amounts of blood clots as shown in image A. They were cleared after extensive snare-assisted suctioning to reveal a pulsatile 7 to 8 millimeter visible vessel along the lesser curvature, which is shown in image B. Image C shows an over-the-scope clip successfully deployed, however, the vessel continued to ooze. Sustained hemostasis was achieved after combination with bipolar cautery, which is image D. Next, we have hemostatic powders. These are highly absorptive mineral powders that activate the clotting cascade upon contact with water. The most commonly used one is called Hemospray, also named TC325. The therapeutic applications for hemostatic powders include tumor-related bleeding, diffuse or refractory bleeding, and adjunct therapy. The advantages of these powders are that they significantly shorten clotting time, are easy to use, have a greater than 95% initial hemostasis rate, and are cost-effective. However, the risk of rebleeding is between 30 to 40%, and the therapeutic duration is only 24 to 48 hours. Side effects to hemospray include embolization, intestinal obstruction, and allergic reaction to the powder. And lastly, if hemostasis fails, the powder attached to the mucous membranes may limit the use of other hemostatic modalities. This image is also from the same journal article by Dr. Yang. It is showing the use of hemostatic powders for diffuse lesions. The images of a 55-year-old man that was hospitalized for a myocardial infarction requiring a drug-eluting stent complicated by cardiogenic shock, resulting in renal and respiratory failure. He developed bloody nasogastric tube output with a 3-point decline in hemoglobin in the setting of dual antiplatelet therapy. An upper endoscopy revealed large amounts of blood clot obscuring the gastric fundus. Image A shows diffusely and actively oozing severe esophagitis. Image B shows the hemostatic powder applied. And lastly, images C and D show successful hemostasis. About 20% of people that have cirrhosis also have gastric varices. When compared to esophageal varices, gastric fundal varices bleed less often but bleed way more severely. The most common treatment modality for gastric fundal varices is cyanoacrylate glue. The problem with the glue is that direct visualization is often obscured during massive gastric fundal variceal hemorrhage. An endoscopic ultrasound allows for direct visualization of the bleeding site, targeting of perforating veins, and confirmation of the obliteration via lack of flow on Doppler. Using embolization poles with endoscopic ultrasound also helps decrease the complications associated with glue embolization. Although most commonly used for varices, endoscopic ultrasound-guided therapy, commonly abbreviated as EUS-guided therapy, can also be used for non-variceal upper gastrointestinal bleeding, such as bleeding tumors and pseudoaneurysms. The disadvantage of this modality is that specialized endosonographer training is required, which is why only a few centers worldwide use it. This image is, again, from the same journal article by Dr. Yang. It is showing an example of how endoscopic ultrasound-guided therapy can be used in a clinical setting. The image is of a 65-year-old man with alcoholic cirrhosis who was admitted for an upper gastrointestinal bleed and on initial esophagogastroduodenoscopy was found to have a gastroesophageal varix with nipple sign as shown in image A. 2 days later, the patient developed a massive hemorrhage with blood obscuring direct endoscopic visualization of the gastric fundus as shown in image B. Image C shows how EUS-guided therapy is capable of visualizing and actively bleeding gastric varix. And lastly, image D shows that hemostasis was achieved using EUS-guided cyanoacrylate embolization with confirmed obliteration of the gastric varix. In conclusion, many new options are currently available for the management of upper gastrointestinal bleeding. Some act as monotherapy, some act as adjunct therapy, and others act as rescue therapy. The indications, efficacy, and safety of these treatment options continue to be defined. Unfortunately, challenges persist despite advancements in research and technology. Some procedures require specialized training that not everyone has, the risk of a rebleed remains high, and complications such as embolization and ulceration may occur. This is why continuous research is warranted to determine the optimal treatment modality for upper gastrointestinal bleeding. Here are the references used to obtain the information and pictures in today's presentation. Please refer to these for further reading on the topic. Lastly, if you've made it this far, thank you so much for watching this presentation. I hope I have provided you with some valuable information on the topic. Feel free to comment below if you have any thoughts, and please don't hesitate to email me if you have any further questions. Thanks, and I hope you have a great day.